All right, awesome. Okay, so gotta give credit where credit's due. I'm borrowing this lecture from a professor of mine. I'm not sure if she's still there. Dr. Kissinger. So she's phenomenal. Um, so she definitely she played a role in my first year in anatomy. So I really thank her a lot. So rotator cuffs. Before we can talk about the rotator cuffs, we have to talk about the joint structure and location. So your shoulder. We are looking at the region posterior, to the shoulder. So you have your scapula here. You have this upper border, lower border. You have the glenohumeral joint here. Obviously the spine of the scapula and your acromion. And then as well, we're going to look anteriorly. We have this region here. Now, typically this area is basically the anterior part of the scapula, which hosts a few of the muscles that I'm going to talk to in a moment. This is a diagram, radiograph that's what radiologists obviously and us use as PTs and medical providers to help see a little bit more in depth of what categories of injury or seeing if there is any issues with the area. So different grooves, different bony landmarks, which actually helps palpation-wise, especially during assessments. This is a girl who she kind of has like no clavicles in a sense. I thought it was interesting. When I saw this, I was confused. I was like, wait, there's something missing there. So I definitely, I was like, whoa, listen, these things happen. Now I'm going to talk, let's see if it shows up. I don't know if I have it here. Okay. So the one thing I just want to go into a little bit before I get into the muscles is the nerves. When you're studying anatomy and physiology, especially in physical therapy, knowing the nerve roots and complexes is something that will carry you, for a lot of conditions in the shoulder. Because if you notice that a certain muscle isn't turning on or firing, well, you can look at it from a nerve perspective and you can look at it from a muscular perspective. Again, very general. So when it comes to nerve involvement, you're going to have this area here. And the nerves that we are going to be looking at, or that are incorporated in the rotator cuff muscles, we have your subscapular nerve, you have the suprascapular nerve, you have your dorsal scapular nerve, long thoracic nerve area. So, and then the last one, which should be, your axillary nerve right here. So these are areas where, now this area in general, this complex is called the brachial plexus. And obviously this is way more towards the cervical spine. And they travel down, and this complex goes pretty much into like that slight upper trap area here, and then it branches out. So it's not like these branches are like all the way down. They branch off very obviously high toward the neck area. So you're talking about this area right here is where they tend to branch off. All right, and going back to just some other muscles in that region. See, okay, so this is, I'm not focusing on the slide intentionally, but so this is the infraspinatus muscle, the supraspinatus muscle here, and the associated nerve root components, and obviously arterial supply. One of the things that that can happen is this, it could be a nerve issue over this region called the scapular ligament. and can tend to cause atrophy in the muscles. So if you know that, oh, this person demonstrates some possible muscle atrophy with just palpation or just movement, you can look here. You can look at an area here, and if this ligament, the superior transverse scapular ligament, that literally is a bridge to where this nerve runs. So if you run inferiorly to that, you're going to look at this. I like the acronym they use for this one. So it's Army over the bridge. So this is the suprascapular nerve, and then the artery, excuse me, and then the navy is under the bridge, suprascapular nerve. So this is intended to identify, okay, what is it's not the artery that's getting, compressed by the calcification. If there's calcification in this area, it's going to automatically hit the nerve. So just a little indicator of, if there is something on an X-ray, like this is more MRI, but if you see something along these lines, you can say that, okay, well, there is perfusion, there's no blood issues. It's the nerve, it's not getting it's choking off. It's a choke point. So that's where you're going to see some of that atrophy. So landmarks, pretty much you have the greater tuberosity and the lesser tuberosity. Now what happens here, now this is obviously a picture of a fracture, but these are the two areas where the rotator cuffs attach. Your lesser tubercle is for the subscapularis muscle, and then your greater tubercle is for your supraspinatus, infraspinatus, and teres minor. Now, these landmarks are important because palpation-wise, this helps us determine where the tendon location is and determine if there is a tendon issue. Okay. So this picture right here, we're looking at the supraspinatus, infraspinatus. The attachment is pretty much looking at the supraspinatus fossa of the scapula here. And the infraspinatus, we're looking at the infraspinatus fossa of the scapula. So there's just regions of the scapula where these muscles originate from, and then they insert on the greater tubercle. Looking at the teres minor, you're looking at the upper 2/3 of the scapula, so pretty much running right around this region here. Then it's going to whip across to the front to that greater tubercle area. Now, when it comes to nerve involvement, it actually makes life a little easy. Supraspinatus, the nerve, is a suprascapular nerve. When it comes to the infraspinatus, we're also looking at the suprascapular nerve. Teres minor, we're looking at the axillary nerve, and subscapularis muscle is a subscapular nerve. So the beauty is that these nerves are associated with their muscle names, so that helps out a lot. Teres minor is axillary nerve, but that's that doesn't help too much. But essentially, just indicating that it helps you remember what the nerves are and where, obviously, where the muscle is and what region is impacted. And the nerves have an associated cervical nerve root, as I was saying earlier. You're talking about C5, C6, C7, C8, T1. You have damage to any of these levels, it's going to follow down. And you're going to see the effect of, if it's here, if it's there, more down here, you'll see that, okay, if you damage any of these nerves, there's going to be some impact. If you even get closer, if there's any impingement going on in the nerve root, okay, they can't lift their shoulder up because it's weak. Well, is the muscle torn, or is there some nerve root issues going on here? So anything with shoulder issues, you're going to more than likely try to clear the cervical spine just to make sure there's nothing else. And it's obviously numbness and tingling, symptoms along that nature can play a role. talk about here. So pretty much, again, I'm trying to keep this light, like I mentioned, making sure that you guys get a nice little general idea. The way, let's see, that's going too far. When it comes to the rotator cuff muscles, the way that the way I was taught was SITS muscles, SITS. So that's going to help, at least, it's a little acronym. Acronyms are a great thing. So it's going to help you memorize what those muscles are and where the location of it is. And typically, so the function of these muscles, so again, they're there to stabilize the shoulder, the glenohumeral joint, and provide external rotation and internal rotation. Now, for those of you who don't know, the motion for internal rotation is going from, this is the neutral position, we're going to go inward, okay? External rotation is outward. That's more of the teres minor and infraspinatus. Now, there's a muscle, so the supraspinatus. The supraspinatus' function is the first about 30 degrees of what we call the motion abduction. So out to the side in this motion. When you know the function of a muscle and the patient says, I can't lift my arm in that direction, it's going to give you a clue as to what's going on. Is there weakness? Is there deficits in strength? And again, the function, again, it's, you got to always take it back to function. You have to remember what is the shoulder doing in that time. So I can't brush my hair. Okay, external rotation. Can't go. I can't tuck my shirt in. Oh, I have to internally rotate my shoulder in order to do that. So, and reaching behind, like to grab something behind your seat, it's internal rotation. So a lot of times people will complain that they can't do these overhead motions. Now, again, I'm not saying that these are all the muscles that can do these, but they can contribute to the issue, and especially when they don't have that rotator cuff stability. So making sure that you listen to what the patient is saying and understanding, okay, I know that they can't do this motion, I can't do this overhead motion. You're looking at those little indicators, and then they're going to show you. You'll ask them, oh, hey, can you show me this motion? And okay, they can't do it. Great. All right, we're looking at this area. So you're able to narrow what you're looking for based on a few movements, and it makes everything get a lot faster, and you're able to narrow down what you're looking into. Let's see, there's a lot looking here. So pretty much what I'm just going to go through are some videos that I have that I recorded. So it's exercises that you may see in the clinic, just to become familiar with, and I'm just going to digest a little bit of the videos with you to see how it's done. And yeah. There's a really nice day outside, so I said, all right, I go outside. Don't mind the random leaves and everything else. All right, so this exercise, the first one I'm going to show you, this is called external rotation stretch. Okay, so as you can see, using a cane or a bar or whatever, this is called the neutral position. My elbow is tucked towards my body, and I am pushing the cane out in that direction. This is stretching. This is actually stretching the muscle that I was referring to, the subscapularis muscle in this position. So again, they can't reach over their head, or they can't reach back. Okay, maybe I indicated the subscapularis is tight, so let's stretch it out in this position. People with post-op rotator cuff later down the line sometimes do this. Patients who just have that general tightness in that area, if they can't reach back and throw, I'm gonna give them this stretch. Now, the combo of this one is, we call it an active assist external rotation. For individuals who have a fair amount of weakness and we can't put them against gravity because they're that weak, so this is gravity supported position. So an active assist motion is pretty much me moving the cane and my arm at the same time. So so now this more becomes a muscular movement versus a stretch. The stretch is obviously the hold at the end. As I go back and forth using the cane to help me, okay, that's actively assisting me into that motion. So that's not the hold. Okay, so all right, so the next, yes, this one. So what the progression, as you progress this way, we are abducting the shoulder. And what is that? And what we're doing is we're creating another degree of the stretch. So as you can see, I'm just repositioning the shoulder, and I'm holding the cane in the hand, and then I'm pushing it back. And as you can see, I'm doing that external rotation motion there. Again, another way. Now, specifically, when you get into this, when you get into more of a range of motion, into this quote 90-degree position, we are looking more about the joint. This is stretching the joint area as well as a little bit of the muscle. So this is probably a harder stretch if it's joint related versus muscular related. It's still getting the combination. I'm not saying it's not. But yeah, this is another variation. If a therapist says, oh, position their arm 90 degrees in abduction and then have them externally rotate, this is the position that you get them into. I think I just went a higher motion probably. Yeah. I just went a higher degree of abduction. Just again, trying to encourage external rotation. This is, okay. Then this exercise, so this is more of another exercise that's not really biasing the rotator cuffs. This is an active assist or shoulder flexion stretch. So the gist is looking at the degree of where my shoulder is. It's close to the ear. So that is what we call shoulder flexion. And again, people who need to stretch in that direction, this is a great stretch. If someone is weak and they need assistance with it, you're just going to see them do that motion if they're that weak. Or certain surgical protocols will say, okay, you utilize a cane to help you get up in that direction. So this is another variant of another active assist shoulder flexion, making sure the palms are up and you're clearing that space for the joint, allowing it to go up further. Now this motion, so again, we're talking about degrees of motion. The degree of motion that I'm trying to encourage is scaption. The reason why we want to work in the plane of scaption is because it composes of all three of flexion and abduction combined at a 45-degree angle. So if you notice, my shoulder is not really near my ear. It's a little bit out to the side. What this is doing is, if someone cannot do a full flexion movement with the cane, we have to modify it. So scaption allows us to get into that overhead motion without creating too much pain and discomfort at the same time. Now again, they're going to make, and this is more of a stretch. Again, this can be an active assist motion as well, just going back and forth in that direction, just with the assistance of the cane. And looks like I'm done. No, I'm kidding. All right. So the next video. So this is a standing version of the external rotation stretch. So I'm making sure my hand is positioned in that upward position, in that palm up position, and then I'm pushing out. Now, depending on how the person, I guess, structurally, looks, if they have an issue with issues bringing the shoulder back, we don't want that. We want to create what we call like a neutral position, like I was mentioning earlier. So if you notice their arms really getting like thrown back toward the wall or whatever object, you want to give them support. So what I tend to do is I put like a half roll, a half foam roll, or I put a towel behind their elbow, so that now they're a little bit more anterior. The shoulder is a little more anteriorly positioned, and so is the elbow. So they're not getting that total extension of the shoulder. And this is just a standing external rotation. So what I'm indicating here is monitoring the hand placement. So making sure that their wrist isn't moving. We don't want that, because that's cheating. That's cheating the exercise. I mean, yes, it's going to probably happen more or less, but we want to encourage. Don't let your wrist move, because now you're even forcing stress on the wrist. This one, I think I'm just trying to get the motion of external rotation, the concept is, watching the wrist. That's what I was getting at. Just seeing from that angle that my wrist is not bending. My wrist is not what we call radial deviating toward the thumb or ulnarly deviating toward the pinky. We want to keep that stable and reduce the amount of compensations when we utilize an exercise. Because patients will find a way to cheat, without a doubt. This is a nice favorite one of mine. This is what we call a sleeper stretch. You're pretty much going to grab, you're setting your shoulder at around 90 degrees, a little bit less. You're going to take the wrist aspect of your of the hand that's on the side that you're laying, and then you're going to press down. And what you're going to get is a stretch in the back of the shoulder. What I tend to see is patients have this, for some reason, nope, that's me getting up. Okay. Patients tend to, for some reason, lift their head when they are doing this. Don't know why. Don't let them have their head up. They're going to strain their neck, and it's going to be painful. So we give pillows. That's why we have pillows in the clinic, to support their head with this stretch. I believe that was the only stretch. Yep. All right. And lastly, I think this is just another different one I wanted to show. This is more a slightly advanced one. So this is what we call a shoulder extension with the bands. This is working the tricep area of the shoulder. This is also helping work scapular movement into the downward direction. So again, this is more like a postural exercise. Okay, now following this, we call this exercise a face pull. Another high degree exercise that the patient, once the patient establishes like an overhead motion. So you are, never mind, I lied. Okay, this is more of a row, a horizontal abduction row. There we go. So that is the face pull. It is a row with external rotation. Now, as you can see, if you look at the shoulders, and the camera angle is a little bit different, but this, my elbow is aligned here. It's not so far forward, or it's not so far back. We want to maintain that position while we're doing this exercise. And at the same time, we're trying to externally rotate the arms. Again, increasing the strength in that, in the rotator cuff muscles. This one, so we call this one scaption. This is working the supraspinatus muscle in this exercise. With a resistance band. So I'm stepping on the band with the same leg, and what's happening is I am trying to get that first 30 degrees of motion. Now, there is an exercise that does make this go higher, and that's fair. That's a fair point. there might be a reason why a therapist will say, okay, I don't want them to go this high. I want them to stay at a certain level. As you increase the tension of that band, it gets harder, which is fine. That's a great exercise. So this is like scaption. You can do it in the scaption position plane, so that's a little bit forward, or you can do it in an abducted position as well. But again, you're turning on the supraspinatus muscle, which is your primary stabilizer when you start initiating an overhead motion. And great, love it. All right. So as you do this exercise, making sure the patient's thumb is up. I can tell you, I've seen patients that do this and their thumb is down. We do not want that. We want to avoid anything thumb down. The reason why, and you can do this with me sitting in your chair. So if you have your thumb up and you go up, let's say even just go out to the side. Great, that probably feels good. Now do it with your thumb down. That's it. That's all you get. What are you doing? You're actually clamping down the available space from your glenohumeral joint. You are decreasing that. So that's why you can do this with your thumb up. Great. Thumb down, and that's even more. And it can get painful too. But internally rotating your thumb and in that downward position creates less available space. So making sure when you give a patient those exercises, or sorry, when you see a patient doing an exercise, making sure the form is right. Because I've seen it, and the patient's like, oh, why am I not getting better? You've been doing the exercise completely wrong the whole time, and it hasn't been caught, which is where being a volunteer is you give us that extra set of eyes. You can see, oh, wait, Anthony told me about this exercise. Oh, their thumb's down. Wait, hold on. Put your thumb up, miss or mister. So making sure you stay aware of what the positioning of these people's arms and hand placement is, because it makes that little detail is the difference between more visits and less visits. So again, it's definitely important that you guys be aware and do research on exercises and observe what the PTs are doing. Nope, that is it. All right.